Okay, in this video, we will cover the most important hematological topic that you need to know for your exam. Okay, so in this video, we will focus on the high yield facts and high yield concepts. So let's begin. So bone marrow evaluation of aplastic anemia. So what will you find in the bone marrow evaluation of aplastic anemia? So in aplastic anemia, the bone marrow will be hypocellular and with full of abundance of the fats. So hypocellular bone marrow with abundance of fat. That is a first high yield fact. Next, what are the major manifestation of the multiple myeloma? So what are the major manifestation of the multiple myeloma? That is again a super high yield. So so hypercalcemia, renal insufficiency, anemia, and the bone pain. So how will you remember these things? CRAB. So C for hypercalcemia, R for renal insufficiency, A for anemia, and B for bone pain. Okay, so next one. Which type of antibody is most common in multiple myeloma? Which type of antibody is most common in multiple myeloma? Can you guess? Yes, you're right. It's IgG. It is the most common. Okay, so mechanism of hypercalcemia in a multiple myeloma. So what is the mechanism of hypercalcemia in a multiple myeloma? So what is the mechanism? Okay, so the mechanism simple. So malignant plasma cells secrete cytokines. So malignant plasma cells secrete cytokines, and that cytokines interleukin 1, tumor necrosis factor alpha, rank L, and they increase the osteoclastic activity. That why the osteolytic lesion in multiple myeloma, and the patient typically present with the bone pain because of this. Okay, so moving to the next one, bone marrow biopsy in the multiple myeloma. So bone marrow biopsy in the multiple myeloma. Okay, I know you know the answer. So it is more than 10% of the clonal plasma cells, right? So if it is a Waldenström macroglobulinemia, so then the answer will be the more than 10% of the B cells, right? So in case of the multiple myeloma, it's the more than 10% of the clonal plasma cell. That is a very, very important. Okay, why blend urine analysis in multiple myeloma? Why? Urine dipstick only detect albumin. So in multiple myeloma, there is a immunoglobulins. So these immunoglobulins are not detected by the urine dipstick. So that's why the blend urine analysis, unremarkable urine analysis in multiple myeloma, and it may show some granular cast as well. Okay, the mechanism of renal insufficiency in multiple myeloma, it's again important. So immunoglobulin, that is the protein that deposit in the glomeruli, and it will lead to renal insufficiency. So this monoclonal protein, that is the immunoglobulin, damage the glomeruli, and it will lead to the nephrotic syndrome, that is a renal insufficiency. Okay, so protein gap in the multiple myeloma, it is elevated more than 4. So what is a protein gap? So protein gap is basically the total protein difference between the total protein minus albumin, right? So in protein gap mean that the non-albumin protein is elevated, and that non-albumin protein is immunoglobulins. So that is a very important, that is a immunoglobulins, right? And the it may be elevated in the other infections, polyclonal gammopathies, infection, connective tissue diseases, excessive monoclonal protein, that is a multiple myeloma, Waldenstrom macroglobulinemia, serum protein electrophoresis can determine if the protein gap is caused by the monoclonal source of. Okay, so why anti-D immunoglobulin used in ITP? Okay, so why it is used? So can you guess why it is used? Okay, you are right. So anti-D immunoglobulin is a first-line therapy for ITP patients who are Rh antigen positive. So what it will do, this anti-D immunoglobulin, it will bind to the positive erythrocyte RBC and that saturate the FC receptor on the macrophages. So let's suppose this is the RBC and this is anti-D immunoglobulin. So macrophages has a FC receptor. So macrophages bind with this and in this way all the macrophages FC receptor are saturated. So in this way, the destruction of the platelet will be reduced, right? At what age is immune thrombocytopenic purpura most commonly? It's a very common question. So it's a 2 to 5 year. So it's a 2 to 5 year age. It is a very common ITP in the children whose platelet count is less than 1 lakh, and it is usually preceded by the viral infection. Uh, Appearance of the platelet and peripheral blood smear of ITP. So appearance of the platelet. So the size of the platelet or morphology will remain normal, but some large size platelet also present because of increased turnover. So both normal size and large platelet. This large platelet due to the increased platelet turnover, right? So it is an autoimmune disorder. ITP is a immune thrombocytopenic purpura is autoimmune disorder. Okay, the most common secondary causes of the ITB, the most high yield, that is a HIV and hepatitis. So HIV and the hepatitis. So this is HIV and hepatitis, very important. The next question is labs of ITP. So what you will find on the labs of the ITP? So platelet count will be decreased. It's really and what happened? So normal coagulation studies, platelet count will be reduced, but platelet morphology remain normal. So isolated thrombocytopenia, that will be again the very important, very high. It is less than 1 lakh. So normal coagulation, normal platelet morphology, and isolated thrombocytopenia, that is a less than 1 lakh. Treatment of the ITP, that is a very important. So platelet count is a very important for the treatment point of view, the ITP. So if the platelet count is more than 30,000, so observation, right? No bleeding, platelet count more than 30, observe the child. Very high. So if it is a less than 30,000, give them corticosteroid. IVIG and platelet, if the hemorrhage. If all of these strategies are fail, then go for the splenectomy. The most wanted question, splenectomy. If you give the corticosteroids, IVIG, platelet transfusion, nothing works, then the next option is a splenectomy. So the destruction side is a spleen. So you remove the spleen and then it will improve the symptom of the patient. Okay. So what will happen to the platelet count and PT and PT involved Willebrand disease? This is a very common and high yield. So in one Willebrand disease, so the platelet count will be the normal. Yes, it will be normal. So platelet count normal, PT normal, but PTT will be raised. Only PTT will be raised in a one Willebrand disease. Okay, so platelet count and PTT are normal, and PTT is prolonged. Why is it prolonged? Because the destruction of the clotting factor 8. So clotting factor 8 is deficient in hemophilia A. Okay, so in indication of the thrombolytic therapy in pulmonary embolism and DVT. So any patient that is unstable, give them immediate thrombolytic therapy. Massive DVT also need thrombolytic therapy. Okay, so thrombolytic therapy is reserved for hemodynamically unstable patient with pulmonary embolism and less commonly for the massive proximal DVT because massive proximal DVT has higher risk of the pulmonary embolism. So that's why and massive proximal DVT is associated with symptomatic swelling or limb ischemia. So massive proximal DVT and hemodynamical unstable patient with pulmonary embolism. Always thrombolytic therapy in this patient. Okay, so next one is indication of IVC filter. So that is a very important indication of the IVC filter. So indication of the IVC filter if the anticoagulation, contraindication if the anticoagulation fail. There are two very important indication of IVC filters. Inferior vena cava filter. So anticoagulation failure and anticoagulation contraindication, any active bleeding, any trauma, any surgery, that is a anticoagulation contraindication. And anticoagulation failure, you give the fully anticoagulated fully anticoagulation drug, but it will not give you the effect of that. Uh, so that if these two things happen, always inferior vena cava filter. So it will prevent the pulmonary embolism. Why immediate anticoagulation is needed in proximal DVT than the distal DVT? We already discussed this question. The proximal DVT has an increased risk of pulmonary embolism. So that's why we give immediate anticoagulation to this patient. So risk of pulmonary embolism is much higher with the proximal DVT as compared to distal DVT below the knee. Okay, why direct X A inhibitor preferred in the acute DVT and pulmonary embolism? So it's a simple. So in case of the acute, why we use? Because it is a rapid onset of action, no monitoring needed, right? So this is very simple. So therapeutic onset, 2 to 4 hours. There is no overlap as compared to warfarin. Laboratory monitoring, no monitoring. Common cause of infectious mononucleosis. So this is very important. Epstein-Barr virus, most common cause, Epstein-Barr virus. So Epstein-Barr virus is the most common cause, and monospore test is positive in Epstein-Barr virus. There is a heterophile antibody test. And cytomegalovirus, that is again another cause of the infectious mononucleosis. There's so many causes of the infectious mononucleosis, but we will discuss the only high yield one, that is Epstein-Barr virus and cytomegalovirus. And in case of the cytomegalovirus, this monospore test is negative, while in case of the Epstein-Barr virus, this monospore test is positive. So common presentation of the mononucleosis. So what are the common presentation of the mononucleosis? So these are fever, hepatosplenomegaly, pharyngitis, and tender lymphadenopathy. That is a very important. Tender lymphadenopathy and especially the posterior cervical node. So very important. Fever, hepatosplenomegaly, pharyngitis, and tender lymphadenopathy. Very important one. So why the contact sports are avoided in the mononucleosis? We already know about the fact that in case of the infectious mononucleosis, the spleen is enlarged. So Always avoid contact sport because of the rupture of the spleen, right? So enlarged spleen can rupture in case of the contact sport. So avoid contact sports until resolution of mononucleosis due to the risk of splenic rupture. Okay, what are the common association with Epstein-Barr virus? What are the common association with Epstein-Barr? That is a super high yield for USMLE Step 1.0 and a Step 2K. So Burkitt lymphoma, that is very important. Nasopharyngeal carcinoma, and that is the most important, particularly in the Asian population. So Burkitt lymphoma, nasopharyngeal carcinoma, and lymphoproliferative disease in transplant patient. So these three high yield association of Epstein-Barr virus. Okay, moving to the next one. So what is the route of transmission for Epstein-Barr virus? So it is a very romantic. So it's a very romantic. So it's also known as a kissing disease. So it's transmitted through the saliva. Yes, I am right. So respiratory secretion, saliva, also called the kissing disease. So Epstein virus, kissing disease. So common in teens and young adults. So it's a very romantic Epstein-Barr virus. So that's why it's common in young adults. So what are the typical signs and symptoms of Hodgkin lymphoma? So what are the typical signs and symptoms of the Hodgkin lymphoma? Okay, so these are painless lymphadenopathy, mediastinal mass, and B symptom, that is a fever, night sweat, weight loss, and pruritus, so pruritus, and alcohol-induced lymph node pain. Okay, so how will you diagnose the Hodgkin lymphoma? It's a simple excision lymph. You will, because the lymph node is involved, you excise the lymph node and take the histology. So you will find the Reed-Sternberg cells. We will discuss about the Reed-Sternberg cells in detail. Okay, so excision lymph node biopsy, Reed-Sternberg cells. You find the Reed-Sternberg cells on this histology. So common association of the Hodgkin lymphoma. So Epstein-Barr virus, we already know that about this Epstein-Barr virus in immunosuppression. So what is the characteristic cells of the Hodgkin lymphoma? So Hodgkin lymphoma, okay, it's a very difficult question. Yeah, it's a very difficult. Hmm, it's a very difficult. Reed-Sternberg cells. So the characteristic cells are the Reed-Sternberg cells, which is a bilobe nucleus. It has a CD15 and CD30 positive P cell origin, right? So very important and the basic thing you need to know about the Hodgkin lymphoma. Okay, what is the most common type of the Hodgkin lymphoma? What is the most common type? Nodular sclerosis. Very simple, very simple. So which type of Hodgkin lymphoma has the best prognosis? Always think about the rich people. Rich people always the best prognosis. So lymphocytic rich. So lymphocyte rich. So lymphocyte rich. Which type of Hodgkin lymphoma has a worse prognosis? Worse prognosis. Who has no money? Poor people. Okay, so lymphocyte depleted. So it's so simple. So rich people has a good prognosis and poor people has a worse prognosis. So always remember like this. Okay, so which type of Hodgkin lymphoma seen in immunocompromised? So it's typically seen in uh, immunocompromised mixed cellularity. Mixed cellularity. So mixed cellularity type of Hodgkin lymphoma. It is the most common in immunocompromised patients. Okay, what is the treatment of Hodgkin lymphoma? So it's a radiotherapy and chemotherapy. So simple, radiotherapy and chemotherapy. So what are the complication of Hodgkin treatment of the Hodgkin lymphoma? So if you treat the Hodgkin lymphoma, the treatment has another complication. Okay, radiation lead to the solid organ, tumor, breast tumor, for example, chemotherapy lead to the hematological malignancies. That is a very common. Okay, which lymph node are commonly enlarged in SLE? Okay, which lymph node? That is a very common. Cervical, axillary, and guinar chain. Okay, so most common complication of sickle cell trait, painless hematuria, gross hematuria. So this is a sickle cell trait. This is not a disease. So sickle cell trait, painless microscopic hematuria or gross hematuria. So sickle cell disorder has another type of the complication. This is a trait. So remember, this is a trait of sickle cell trait. Complication of the sickle cell trait. So common complication is the painless hematuria. We already know about that. Gross hematuria and why it has happened. Because sickling in the renal medulla. Because sickling in the renal medulla. Okay. So next is a hypersthenuria. So hypersthenuria is an impairment in concentrating ability. Impairment in concentrating ability to urine. So kidney lost this capability to concentrate the urine. So less commonly, UTI during pregnancy, splenic infarction are common. Is a uncommon in sickle cell trait, but is it common in sickle cell disorder? Okay, is that splenic infarction occurring high altitude? Okay, acute severe anemia and sickle cell disease. Acute severe anemia and sickle cell disease. That is a two causes: aplastic crisis and splenic sequestration crisis. So aplastic crisis, the reticulocytes percentage will be less than 1. And there is a no splenomegaly. So very important to differentiate those things. Aplastic crisis and splenic sequestration. Okay, so splenic sequestration crisis increase reticulocytes, splenomegaly, right? Splenomegaly present in case of the splenic sequestration crisis. Okay, most common cause of the aplastic crisis in sickle cell disease. That is very famous parvovirus B19, very high yield. Okay, so anemia is typically less than 6 gram per deciliter in case of aplastic crisis. So generally present before age 15. Okay, so difference between thalassemia minor and iron deficiency anemia. So both will typically present with the microcytic anemia. So MCV will be decreased in both. But in case of thalassemia minor, the RBC count will be normal, normal or increase. So this is a simple difference, but it is a very important, and very tricky when you encounter the question. Okay, so RBC disproportionately elevated RBC count and decrease MCV, right? In case of thalassemia minor, while in case of iron deficiency anemia, MCV typically take place when the hemoglobin is less than 10 gram. Okay, vitamin B12 absorption and a pernicious anemia. So pernicious anemia. So vitamin B12 absorption in the pernicious anemia. So let me discuss the very important concept that connect the physiology to the pathology. Okay, so the salivary glands, what does they do? They do R protein. So this R protein bind with B12, right? So this B12, when it goes to the stomach, this is our stomach. Okay, so stomach. So what will happen? It This B12 will bind with intrinsic factor. Intrinsic factor. Okay. So when it reach to intestine. So what will happen? The proteases will cleave this intrinsic factor from B12, and this B12 is observed in ileum, right? So for absorption of vitamin B12, salivary gland will be intact, stomach will be intact, pancreas will be intact, and ileum will be intact. So any damage in these four structures will lead to the deficiency of this vitamin B12. So if this deficiency takes place, it will lead to the megaloblastic anemia. So that is very common in developing countries. Okay, so in con- a condition in which autoimmune antibodies produce again the parietal cells and intrinsic factors. So parietal cell produce intrinsic factor. So this is known as a pernicious anemia. So pernicious anemia is a condition in which autoantibodies produce against parietal cells and intrinsic factor, right? That is a very important one. Okay, so causes of pancytopenia. So what is a pancytopenia? Is a pancytopenia is a decrease of two or more than two type of blood cells, right? So it will be the bone marrow aplasia. So bone marrow aplasia, the infection is very important. So which infections? Again, that is a HIV, hepatitis, and it's a parvovirus. That is a very important cause of bone marrow aplasia. Bone marrow infiltration. So bone marrow infiltration is a malignancy and some infection like TB and fungal infections. Mature cell destruction. It may be the intrinsic extravascular, intrinsic, intravascular, and extrinsic extravascular. So extravascular means the destruction due to the spleen. Which cancer risk increase in a pernicious anemia? Okay, so which cancer risk? It's how to remember which cancer. So it's a simple. So autoimmune antibodies produce against parietal cells and intrinsic factors. So where the parietal cells and intrinsic factor present in the stomach. So the gastric cancer is risk of gastric cancer is increased in case of the pernicious anemia. It's so simple. So in pernicious anemia, what will happen? The atrophic gastric mucosa undergo intestinal type metaplasia, which dramatically increase the risk of the gastric cancer, right? So why the patient of the pernicious anemia require esophagogastroduodenoscopy? I hope you know the answer. Why you know the answer? Because I explained already and explain it very well. Okay. So why gastric cancer? You know the answer. Basophilic stippling. So this is a typically some pictures. So basophilic stippling it takes place in thalassemia that are heavy metal poisoning.